Good morning, everyone. I'm Jen Clays from the Division of Newborn Medicine, and it's my absolute pleasure to introduce today's panel of speakers for Grand Rounds. Dr. Gysella Muniz is an Associate Professor of Pediatrics in the Division of General Academic Pediatrics. She joined Children's in 2015, and since that time has advanced how we deliver newborn care by serving as UPMC's Regional Director of Quality Newborn Care and also the Medical Director of Newborn Nursery Services at Magee Women's Hospital. Her quality improvement work is focused on decreasing variation, policy development, and outcomes improvement through the implementation of multiple clinical initiatives within UPMC's 15 birthing centers. Dr. Lois Bangiolo is a neonatologist at Children's Hospital of Pittsburgh and Magee Women's Hospital and an assistant professor of pediatrics. She received her medical degree from Columbia University and completed her pediatric residency at Inova Fairfax Hospital. She then completed a fellowship in neonatal perinatal medicine at Dartmouth Hitchcock Medical Center, where she also received a master's of public health. Since joining our division, she has become our go-to expert on all things related to infant feeding and breastfeeding in the NICU. Dr. Jill Demirci is an associate professor, the department vice chair for research and scholarship, and director of the Maternal, Perinatal, and Reproductive Health Research Hub at the University of Pittsburgh School of Nursing. Her NIH-funded research advances lactation support interventions, particularly in the area of preventing and managing insufficient milk supply. And Alison Keating is the mother of 4 breastfed children, a registered nurse, an international board-certified lactation consultant, or IBCLC, and a La Leche League leader. In 2022, she completed a master's degree in nursing from the University of Pittsburgh focused on education and quality improvement initiatives. She currently works as a postpartum nurse in IBCLC for UPMC Altoona and co-leads the UPMC System Breastfeeding Committee. Please join me in welcoming this group as they present their talk, State of the Science, Strength of the System, Integration and Advancement of Evidence-Based Breastfeeding Support at UPMC.
Thank you so much, Dr. Clays, for that wonderful introduction. Good morning, everybody. Happy Friday. Today we're here for this great talk, State of the Science, Strength of the System, Integration and Advancement of Evidence-Based Breastfeeding Support at UPMC. But today we want to start addressing the elephant in the room. And yes, all the hundreds of people that we have here present, hundreds of thousands, right? Because it's the NFL draft. And with that, we are bringing you guys a 5-star recruit. The scouting report will talk about human milk, which is our 5-star recruit, bringing elite bioactive performance, strong developmental potential, excellent endurance and adaptability, and it's projected to be our first-round pick. At least ours, or if the NFL would accept infants. But let's jump into our objectives. Today, we'll be describing the current state of breastfeeding and human milk utilization across UPMC, including in quality improvement initiatives. We will summarize major scientific advances in human milk biology, including research-oriented advancements like lactation physiology, milk composition, other research-related advancements like organoids and point-of-care milk analytics. We will explain the evidence supporting breastfeeding level approaches to breastfeeding and all the amazing projects that are happening here at UPMC with community-based models, baby-friendly practices, and equity-driven initiatives. We will share the role of breastfeeding and pasteurized human milk in our nurseries and NICUs, especially from the impact on breastfeeding outcomes and clinical indications. And also sharing a little bit the lessons we've learned from implementation projects across UPMC. And finally, we'll identify future directions in lactation science and care. But why breastfeeding matters? Exclusive breastfeeding, it's a very well-known cornerstone of maternal child health. It provides optimal nutrition and immunologic protection during a critical window of development. We also know that it reduces infant morbidity, right? Respiratory and gastrointestinal infections, necrotizing enterocolitis for premature babies, and even sudden unexpected infant death syndrome as well. There is also long-term benefits across the life of across the life course of children, and also parents as well, right? Lactating parents, benefits can show up as early as decreasing postpartum hemorrhage, but also decreasing the risk of breast and ovarian cancer and type 2 diabetes. And for the children, in terms of long-term benefits, lowering the risk of obesity, type 2 diabetes, cardiovascular disease, but also improving neurodevelopmental and cognitive outcomes as well. Breastfeeding also, it's a public health and equity issue, right? So despite strong evidence of how great breastfeeding is, the rates, national rates, local rates, they continue to be below national standards. With persistent disparities, right, especially by race, socioeconomic status, and medical complexity. So effective breastfeeding support is not just a parent's choice. I think it goes well beyond. It's really a system's responsibility. It's a society responsibility. All right. So despite strong evidence, multiple barriers continue to undermine exclusive breastfeeding efforts. When we're going to go over a couple of those. We'll start with culture, especially focusing on the culture of supplementation, sometimes what we call the just in case, because early non-medical indicated formula use remains super common, often driven by parental concerns of low milk supply. So how many times we see like, I don't have enough milk right at delivery, right, hour one. That happens extremely commonly, but also concerns of potential weight loss or even medical complications such as hypoglycemia, for example. We know also that supplementation, even when temporary, disrupts lactogenesis and parental confidence, reinforcing unnecessary dependence on formula. Inconsistent messaging, and especially messaging within the healthcare system, because there could be variation in provider knowledge. There could be also variation in risk tolerance that we have, send babies home. And time pressure leads to mixed recommendations as well. So families may receive conflict advice, particularly during the birth period and early postpartum period as well. Structural and social barriers. There's limited access sometimes to skill lactation support, especially after discharge and the early follow-up. Not all the pediatric practices have appropriate lactation consulting support. There sometimes can be physical separation as well, like, unplanned NICU admissions or even transfers to another hospital when there's the need for higher level of care. There's early return to work or inadequate workplace accommodations. The other thing that I was thinking a lot on in terms of structural and social barriers is growing problem here in Pennsylvania, which is the maternal healthcare deserts. And some of you might heard of this already, but on the 67 counties that we have here in the state of Pennsylvania, 23 have no labor and delivery services. And the largest desert, so if you put all these counties together, I think it's 7 or 8 counties. That's a very significant geographic area affecting our maternal and infant care. So more to come on that, but it's really a negative evolving situation. Also persistent racial, socioeconomic, of course, and medical disparities. Social media and, the influence of digital platforms. So social media platforms amplify anecdotal experiences, viral hacks. And boy, we know this right now, nowadays, with the vaccine hesitancy also. So, early supplementation norms can change a little bit there, especially with the fear-based narratives. Some of you might, have heard of make your own formula, toxic-free, preventative-free, preservative-free, or hugs as crazy as the family bed, so that we all sleep together on this gigantic bed, right? Always thinking with my brain on safe sleep also. So, rapid consumption of misinformation can really erode trust in medical care guidance and evidence-based breastfeeding support, and many other things, as we know. So, and just to provide a little bit of big picture current state within our system, as Dr. Clays mentioned, we have 15 birthing centers, and of those, currently 3 are baby-friendly designated. That is Lititz, Harrisburg, and Williamsburg. So we still have a lot of work to do and a lot of opportunity for improvement. Some of you might be very familiar with this. Don't go too crazy trying to find numbers. This is just a big general picture of CLIC, which is our clinical analytics dashboard. It's a labor of love going on for many, many years now. It's not 100% accurate, as we are transitioning into a universal healthcare record. Some of the hospitals are starting to pour in more data. So a lot of work going on behind the curtains by the clinical analytics team for validation. But just as you have an idea, through our all delivery centers, we deliver approximately 21 to 23,000 infants. Last year, we delivered 23,100, as you can see there. But our breastfeeding rates as a system are quite low. They are around 26-27%. And if we look at McGee, which it's a hospital that we've been investing a ton of work and time in validating the data. We deliver 10,000 babies plus minus every year. So that's almost half of the babies that we deliver in UPMC. Those breastfeeding rates are at about 36%. And the non-exclusive breastfeeding rates, it's about 44%. And that's our low-hanging fruit, because we need to know our audience, right? We need to know what the goals, the parental goals are. And many people might just come right from the get-go, not interested in breastfeeding at all. Maybe sometime they're interested in supplementation in some way, shape, or form. So that is 44% of the cases. And we do really have tremendous opportunity to increase our exclusive breastfeeding rates. Again, at McGee, it's about 36%, so we're a little higher than the overall system, but a lot of work to go.
Good morning. So I'm very excited to tell you about the current state of the science and share some research in the area of human milk and breastfeeding. So what is the current state? So the field of human lactation and research that's going on, there's many different areas right now. So we have omics, we have tech and devices to better support families. It's a little bit fragmented at the current moment. There's a lot of people working on different things and not necessarily working together or collaboratively. But the good news is that there's major recent investments. So one example is the NICHD. They have the Begin initiative, which is focused on the ecology of breast milk and understanding what are the various inputs from the mother, the infant, and the environment into the composition of human milk. And so for the clinicians in the audience, before we get into some of the exciting areas of research, I just wanted to share these 2 research-based databases. One is LactMed, if you've not heard of it. It is a database that reviews the latest research on pharmacology and how medications can impact breastfeeding families and whether a medication is safe or not. So that's sort of the go-to if you are thinking about a medication with a breastfeeding parent and whether it's safe or not. The other is the Academy of Breastfeeding Medicine protocols. And so this is an organization that boils down the latest research evidence into very digestible ways that we can interact with breastfeeding families. And so they have protocols that span the gamut from how to supplement if a baby has hypoglycemia, or for a mother who has a substance use disorder, how do we counsel on breastfeeding for those families, but many other ones as well. I just want to take the next couple minutes to talk about the frontiers, the really exciting directions that we're moving in human lactation and breastfeeding research. And so I'm going to share 4 of them. And the first one is, over the past 5 to 10 years, we've really started to conceptualize human milk as not just nutrition, but as a complex biological ecosystem, so a signaling system between the mother and the baby, right? And so we know that the milk microbiome, if you will, has all these different inputs, right? So from the maternal gut, we're getting input. From the baby's oral microbiome, we're getting input. And all of that is influenced dynamically by the environment. And so there's this crosstalk between the mother and the baby through milk, right? We also are learning more about how breast milk varies by feeding mode. So whether a parent is pumping and feeding exclusively expressed milk versus directly at breast, that milk is going to be very different, right? We also know, and we've known for a long time, that human milk varies by the time of day and the stage of lactation. And also environmental exposure. So we're learning more and more about how heavy metals, pollutants in the environment can impact human milk. And maybe perhaps some of this explains some of the heterogeneity we see in breastfeeding outcomes in terms of, how effective breast milk is in improving infant health outcomes and maternal health outcomes as well. The second frontier really concerns how we study human milk. And we've made incredible advancements in the past couple of years in instruments and resources that we are using to do this. The first that I wanted to mention is biobanks. And so for those of you who are not familiar, we have actually one right here in Pittsburgh, the Human Milk Science Institute and Biobank, which is affiliated with our Mid-Atlantic Mother's Milk Bank, which is in Pittsburgh. So these banks provide human milk samples that are often connected to maternal and infant electronic health records, as well as sometimes survey data as well. So we can really understand how these things impact the composition of human milk. There's also mammary organoids, which I was really surprised to learn about over within the past year. So basically a breast model outside the mother that we can study how breast milk is produced and how medications filter in and out of human milk. There's also point of care testing devices that are actually now becoming even commercially available that allow us to study human milk composition. And so we can detect things like potassium and sodium content that can signal early inflammation that could indicate mastitis, which is a breast infection. Okay, and sort of transitioning from the biology side of it, sort of my area of expertise is breastfeeding support. And this is where I get really excited about where we're headed. And so we've really evolved over the past 10 years from sort of conceptualizing the best way to support breastfeeding families as individual education to understanding that the best ways that we can support are multi-level and delivered over time. So it's not just at the individual level, it's at the community level. It's where people live and they work, right? We also know that support has to meet people where they are. So it's not just in person in clinical visits. It is on demand and informal, right? So there's apps. Telelactation is becoming a big thing now, and it's widely available for a lot of families. Breastfeeding friendly communities. We talked a little bit in the prior slide about baby-friendly hospitals. Breastfeeding-friendly communities is the equivalent in the community. So are we designing daycares, places of work to best support families where they are living and working? Also wanted to share, for those of you not familiar, UPMC has an app, Your Baby's Birth and Beyond. I think it used to be called Yomingo. And this is a great resource for families that is actually available in multiple languages that provides evidence-based breastfeeding support throughout the lactation journey. So just wanted to do a shout out. You see that on the left-hand side of the screen. This is actually a great Pittsburgh-based company. I believe it's called Kangaroo Maternity, started by a Pittsburgh native, Sarita Gordon, pictured there. And they offer this mommy concierge service, so meal delivery and laundry service. So the things that can really end up impacting breastfeeding, because breastfeeding is time intensive. What can we take away from families to make that possible? Okay, and then the last frontier I wanted to talk about is actually the number one reason why people, or the number one problem people give for why they stop breastfeeding, and that is insufficient milk or feeling like you don't have enough breast milk for your baby. And so what we used to sort of tell families and sort of the thinking was that, as long as you are breastfeeding enough and, breastfeeding is supply and demand, you will make enough milk for your baby. And what we're actually discovering is that there are many biological influences into milk production that we had not previously considered. So now we're learning more about how endocrine influences influence milk production. So things like type 2 diabetes and PCOS can really impact milk supply. We're learning about genetic variability and how these can impact milk supply and the mind-body connection and how important that is. Alongside that, we're developing better solutions for families that are experiencing this, because the majority of families really do want to try to breastfeed. One of these you'll hear about in the coming slides is the availability of pasteurized donor human milk, even in the well baby nursery, so not just for preterm babies. Another thing that seems to be increasing is peer-to-peer human milk sharing. It often occurs through family and friends first, and then sometimes transitions to these online Facebook groups, right? They're unregulated. There's questions about safety in the clinical setting. So how can we have those risk-reduced conversations? How can we help patients, first of all, understand that it's happening and have those conversations? And then what solutions can we develop to make it a little bit safer if families are going to try to get milk in this way? And then finally, this is a bit of an ethical dilemma, but bioengineered milk is on the horizon. And so researchers creating or trying to replicate human milk. There's one company, BioMilk, that is trying to do that right now. And then finally, we talked about some frontiers in research, and I just wanted to share two examples of how research just in the past 5 years has really influenced clinical practice. One is in the area of HIV and breastfeeding. And so our old guidance used to be in the United States, if a mother was HIV positive, because in the United States we have access to safe water sources, that formula would be the choice because you prepare formula with water, right? Research has evolved to show that mothers who are stable on ART and have low viral load, there is extremely low risk of transmission of HIV through breast milk, right? And so the guidance has evolved to share decision-making for mothers who are HIV positive now on the decision to breastfeed postpartum. And then the other area I'd like to highlight is breastfeeding duration. Our old guidance used to be to breastfeed, to exclusively breastfeed for 6 months postpartum and then continue to a year or longer, as long as the mother and the baby both continue to desire that. And sort of the thinking was there's not much benefit of breast milk beyond a year. Well, research evolved. We have systematic reviews and meta-analyses that actually show that there is continued benefit to the baby, health benefits from breastfeeding past a year. And so the AAP came in line with the World Health Organization guidance for duration of breastfeeding for 2 years or beyond, as long as the mother and the infant both desire. Now, whether that's actually possible in our society, breastfeeding is already challenging, is another issue, but it's sort of the precedent and one that we need to move toward to help and support families in that way. Okay.
Good morning. I'm Alison Keating. I'm one of the lactation consultants from UPMC Altoona, and I would love to share with you one of the initiatives that is moving across the maternity hospitals of UPMC. We call it our BRIM initiative, which stands for Bridge Human Milk, and it's using pasteurized donor human milk for supplementation in the well baby unit for breastfed infants. So Dr. Demirci touched on the global and national recommendations for breastfeeding exclusivity and duration. But I always think that it's a really important framework to start with when we talk about lactation support, right? These are our goals as clinical, as healthcare providers. We want to assist families to maintain 6 months of exclusive breastfeeding and then to continue offering human milk with other complementary foods for 2 years and beyond. So always good to start with this framework. Back in the late 1980s, the World Health Organization came up with a cluster of evidence-based practices that birthing hospitals can adhere to that helps us get families off to that great start, right? The 10 steps to successful breastfeeding. And they cover everything from having a written breastfeeding policy that's communicated to all staff, prenatal education for families about breastfeeding, skin to skin in that hour post-birth, and then after hospital discharge, making sure that we connect families with support in the community. So the 10 steps are very broad. And this morning, I'd love to focus on step 6, which deals with supplementation. And I think Dr. Muniz touched on the fact that this is a complicated subject, but the recommendation from the World Health Organization is offer breastfeeding infants no other food except human milk unless there's a medical need to do so, right? That's the standard we're working toward. So this is a very high level, not detailed graph that is drawn from that clinical analytics dashboard that Dr. Muniz mentioned. The blue line are all the infants born throughout UPMC that were not admitted to NICU care. So this is healthy full-term newborns. This is late preterms that were admitted to level 1 care. The red bar next to it are the infants that are discharged after the birthing hospital admission, exclusively human milk feeding. The purple bar are mixed feeding infants. So they were fed some formula and some human milk. And then the orange bar is exclusive formula feeding. So I'd love for you to take a look at the height of the blue bar and the height of the red bar. And there's our opportunity to really support human milk exclusivity, especially in those early days postpartum. Again, supplementation, it's complicated. There are obviously times when we have to give babies something more to eat in order to maintain safety, right? Hypoglycemia, jaundice, a weight loss that's concerning. These all make sense. I think that as maternal complexity grows, sometimes these instances grow as well. But then there's the whole other layer of parental request, which really speaks to our opportunity to provide a lot of education, a lot of preparation in the prenatal period, but then also provide that very, very comprehensive support during the birth hospital admission and after, so that we can ask questions, find out what the concerns are, address those, talk about normal newborn infant feeding behavior, right? Which is not what some parents are expecting. In addition, I'd like to just circle back to Dr. Demirci's references. The Academy of Breastfeeding Medicine has a wonderful protocol on supplementation of the healthy full-term newborn. And the information that's in that protocol was drawn into our UPMC system-wide infant feeding policy. So we use a lot of their recommendations. In the past, and when I say in the past, I'm thinking, the past 75, 100 years, when we have needed to provide an infant more food, infant formula was what we had available to do that, right? So that was the extra volume that we had available. But in recent years, we've come to understand that offering infant formula to breastfed babies in the early postpartum period carries risks. It can sensitize them to allergies, both cow's milk protein and other food allergies. We know during that really pivotal period, that sensitive period where the microbiome is developing, that interfering with that typical development can put infants at risk for other things as well. Obesity and overweight is one of them. If we offer infant formula in that newborn period, we're already removing the possibility of exclusive human milk feeding, right? We've already interrupted that. But what we know is when we provide formula in that sensitive period, we're also reducing the duration that families breastfeed, right? We know that formula leads to earlier weaning, a shorter duration of breastfeeding. And then one of the newer findings, which I think is very compelling, is that if we provide infant formula supplementation to an infant in the now, we're also affecting the family's decisions to breastfeed subsequent children. They are less likely to breastfeed, and if they do, they're breastfeeding for shorter durations. So I think it's very compelling to see how far-reaching the decision is to offer infant formula in the early postpartum period. So enter pasteurized donor human milk. Many of you who work in NICU and intensive care settings have probably also already had a lot of experience with this. We are so fortunate to have Mid-Atlantic Mothers Milk Bank right here in Pittsburgh. They're a member of Human Milk Banking Association of North America, which is their accrediting body. And basically, families that have more milk than their infant needs are able to be screened by the milk bank. They have blood tests done, and once they are approved, they can send their milk to Mid-Atlantic Mothers Milk Bank, where it is processed, it is pasteurized, frozen, and then shipped out to hospitals across Pennsylvania, New Jersey, Maryland, West Virginia. So they have a very far reach. It's a really safe, wonderful product, and the use in well baby units is growing nationally and across the state of Pennsylvania as well. We know that pasteurized donor human milk allows us to maintain that human milk exclusivity. Not only that, but when families are provided with donor milk in the postpartum period, they are able to maintain breastfeeding duration. We know that they breastfeed longer than families that are offered infant formula. Families see it as being temporary. They see it as being a bridge to their own exclusive breastfeeding, which is terrific, where a lot of families see formula introduction as sort of the beginning of the end, right? Breastfeeding's not working. This is the beginning of the end. They see it as being healthier than manufactured formula. It supports their mental health. It supports their well-being. I've had families tell me, I didn't feel guilty offering donor milk. I felt like good about that decision. So it's a huge patient satisfier as well. So it checks a lot of boxes. What are the issues and concerns? Well, infant formula is given to birthing hospitals and children's hospitals for free. There's not a cost to that. There is a cost for donor milk. It's about $4.16 an ounce, or about $15 for the 100 ml bottle that is used most commonly on a postpartum unit. I think that public perception is really shifting. People are starting to understand more the importance of using human milk in the early postpartum period. But early on, when we began this, the idea of, you're going to use the milk of another person to feed my baby, right? It was just sort of a little bit to get their head around. It is more complicated to use in the clinical setting, right? So formula, pick a bottle off the shelf, pour out your volume, and you feed. When you're using donor milk in the clinical setting, it needs to be stored in freezers. It needs to be defrosted safely and appropriately. It's stored in refrigerators for specific amounts of time. Batch numbers need to be documented. It needs to be scanned. Infant feeding needs to be connected to those batch numbers. So there's a lot more complexity. And when you are working on an initiative or a change, that there has to be a culture shift then with staff on a unit to make that change happen, right? Those changes are not easy to shift. So in 2021, UPMC Altoona had just finished our state breastfeeding initiative to align with the 10 steps to successful breastfeeding. It was called the Keystone 10 Initiative, and we'd also added a electronic milk scanning system to our EMR. So we had the capacity to handle donor milk. So we talked to our leadership. We got our interdisciplinary committee together, pediatric providers, OBs. We also went to system leadership as well, because this was the first time this was going to be used in UPMC system, came up with criteria for supplementation, wrote a policy based on best practice and protocol. We created staff education that talked not only about the importance of maintaining human milk exclusivity, but why pasteurized donor human milk was a safe product. We could have confidence in that, and also how to manage that on the unit. For patient education, we were super fortunate because Mid-Atlantic Mother's Milk Bank makes beautiful graphic patient education pieces. So we were able to pull those in. And to help defray the cost, Mid-Atlantic Mother's Milk Bank also provided us with a grant for a 60% off discount for the first 6 months of use. So that sort of helped soften that financial blow a little bit. Our legal team helped us create a permission form. It's a little different than the consent form that you may use in NICU use. It just talks about the fact that parents have been educated, they understand why we're using this for therapy, and that they are in agreement with this. And then we needed some platforms for data collection, right? We want to show if we're putting the time and the money and the effort into this, that we're going to have some good results. I know that this slide is very busy, but our project was to then take a look at 4 months within a 3-year time period, 2021, before we started using pasteurized donor human milk, 2022 and 2023, and see within this time span if we were able to increase the rates of exclusive human milk feeding at discharge for 2 medical concerns that we see supplementation for most often, and that was hypoglycemia and hyperbilirubinemia, and then also for parent requests to see, can we make a difference in parental request for supplementation? And so our findings were, yes, we were able to increase exclusivity at discharge if we were using pasteurized donor human milk for supplementation. We saw a more significant improvement with medical supplementation than we did with parental request. So we were able to extend our improvements in exclusivity into the 2nd year of the initiative. So it wasn't just the excitement and the hype of, year 1. We were able to continue those gains into our 2nd year as well. And we saw less significant improvements in our exclusive breastfeeding rates when parents were requesting supplementation. And I think, again, this speaks to the opportunity for that support, for the education prenatally, and to really sort of shift the conversation to make human milk the standard and the go-to. So we began using this in 2021, and one of the beautiful aspects of being part of a hospital system like UPMC is that when something is trialed and there's a little pilot program and it goes well, we're able to extend that throughout the system. So in 2023, McGee Women's Hospital in Pittsburgh began using donor milk on their well baby unit. By then, there were lots of facilities that were interested, so we formed sort of an inter-facility team to talk about wins, challenges, materials sharing, all of that. And in 2024, we were able to add Horizon, Lidditz, Hammett, and then Harrisburg to the team. In 2025, Carlisle began using donor milk in the well baby unit. And in January of this year, Memorial was added to the group as well. So it's beautiful to see that best practice really spreading across UPMC system. We had such a great experience with our donor milk program that we decided we wanted to become a depot at UPMC Altoona to give back to Mid-Atlantic Mother's Milk Bank. And what that means is that screened, approved donors in our area can just swing by the front entrance of the hospital and drop off any extra milk with us. We're able to store that in our freezers and ship that back to Mid-Atlantic Mother's Milk Bank in bulk. It does 3 really important things. It increases awareness. It brings human milk to the conversation. People are aware that we are supporting this system. It adds convenience for donors, so they're more likely to do it, right? It makes it a lot easier than wangling boxes of packing materials and an infant car seat into the post office, that kind of thing. And it also reduces costs for Mid-Atlantic Mother's Milk Bank. So we're able to keep their costs lower. We have a vested interest in keeping the price as low as possible. And so it's helpful for them to do that bulk shipping as well. In May of 2025, UPMC Hammett also became a donor milk depot. So hopefully that is going to start spreading as well. And we're just thrilled to see this initiative grow. Thanks so much.
Hey.
Hello, I'm Lois Bangiolo. I'm one of the neonatologists here. And as a neonatologist, I'm excited to expand our discussion into the NICU setting, talking about both reviewing the use of donor milk in the NICU, as well as discussing the additional challenges that a preterm birth can cause with breastfeeding. So when I go into a prenatal consult and ask the mother what her feeding plans are, she'll sometimes look at me and say, well, I was planning to breastfeed, but... And then we can discuss, can premature infants learn to breastfeed? And the answer is absolutely. They're going to have the opportunity to learn to breastfeed, but not immediately. And that's both due to the challenges from that preterm birth on both the mother and infant side. So preterm infants don't even start to develop the coordination that they need to coordinate that suck, swallow, breathe pattern that's needed for oral feeding until about 33 to 34 weeks gestation. So if you're having, a 24, 25-week baby, that's 10 weeks before that baby's going to even start to begin to orally feed. And that coordination, again, when it develops, it's just starting to develop. So it needs time to fully develop, and then the infants need time to develop feeding stamina. Because if you just go and ask this, a 34-weeker to breastfeed, it can be like asking you to go run a marathon without any training. And then on the maternal side, the preterm birth also affects the production of breast milk, usually in a detrimental fashion. Both the preterm birth causing a decrease in the time of pregnancy, so you have less time to develop that glandular tissue to produce breast milk, as well as oftentimes medical comorbidities such as preeclampsia, which also can impact the production of breast milk. And then the very fact that the infant is premature and ends up in the NICU means that there's a separation of the mother and their baby. And that is compounded by just the stress of having a medically fragile baby in the NICU. And both of those we know have a significant impact on the production of breast milk and breastfeeding. And then, as I mentioned, that delay in direct breastfeeding, we know that when you place a baby to breast, there's a positive feedback loop that helps with the production of breast milk. And that is, of course, delayed by weeks and weeks sometimes. So given that premature infants cannot even start to orally feed at birth, how can we best support breastfeeding the provision of human milk in the NICU? So first, I want to shout out our wonderful lactation consultants like Alison Keating. We have a team in the NICU that are both specially trained in breastfeeding, but have the additional expertise to help with the challenges of breastfeeding a premature baby. Also going to talk about our donor milk use in the NICU and other practices such as non-nutritive breastfeeding, protected breastfeeding period, and targeted fortification of breast milk, all of which help support breastfeeding and the use of human breast milk in a time when these preterm babies unfortunately can't direct breastfeed. First, non-nutritive breastfeeding. This is sometimes also called dry latching. And what it involves is placing a baby to a pumped breast so that they can practice the skills that they're going to need for breastfeeding. And since we're not expecting them to eat at this point, this allows them, again, to practice. So practice those skills, practice latching, practice being in the position for breastfeeding before that they're ready to breastfeed, and improve those oral motor skills that they're going to need when they're ready to start feeding. And bringing these babies skin to skin and practicing breastfeeding can both promote bonding and improve our breastfeeding rates, and again, support that positive feedback loop to support a breast milk supply. And it's been found to non-nutritive breastfeeding and non-nutritive sucking has been found to reduce the time for these infants to get to full oral feeds and thus reduce the time to hospital discharge. So shortening that NICU stay, getting these babies back home. And as I said, this is practice. So I'd like to think about this as feeding for practice, not for nutrition. And that can reduce the stress of both the baby learning that new skill, the mother learning that new skill, and the stress of, is my baby going to eat my mouth? By giving the mindset that this is, again, practice. We don't expect them to be taking feeds yet. And then when these babies are ready to start taking feeds by mouth, we offer what's called a protected breastfeeding period, so that these babies can have their first oral feeding experiences at the breast before the introduction of the bottle. Again, this can help them establish direct breastfeeding, giving them that time to practice and learn this new skill now that they are starting to take milk. Again, it helps sustain a mother's milk supply, And for the most part, the milk flow at the breast can be easier for infants to regulate that coordination, that suck, swallow, breathe pattern that they need to successfully eat while they're still breathing. And as I mentioned, premature birth affects the production of breast milk. And to support the provision of human milk in the NICU and that use, we do use that donor milk to both supplement the mother's milk supply at the beginning and to ensure that our medically fragile babies receive human milk during their most fragile period. And almost all NICU infants here receive donor milk. And we provide it until the infant is both greater than 34 weeks gestation and greater than 1,800 grams. And again, that supports the mother's milk supply if it's not sufficient, and make sure that these babies still continue to receive human breast milk until they're bigger and stronger. And while donor milk doesn't have all the immunological benefits of maternal breast milk, particularly for extremely preterm babies, that use of donor milk is associated with a reduction in necrotizing enterocolitis, which is a severe inflammatory condition of the gut that can lead to gut perforation, sepsis, and death. We know that premature babies have additional nutritional needs. Breast milk is fantastic, but these babies do, because they missed out on that nutrient transfer in the third trimester, they do most of the time need supplementation with either additional calories, protein, phosphorus, calcium, really to help them grow. And one thing that is fantastic that the Mid-Atlantic Mother's Milk Bank provides is donor milk that's made with higher calories per ounce. And that helps us really support the nutritional needs of our babies. And finally, I'd like to discuss something really exciting that we've started to do at our NICU here at Children's, and that's targeted fortification. So as I mentioned, premature infants do require additional nutrients for adequate growth. That unfortunately, with all the benefits of breast milk and human milk, it can't quite meet those needs. And so most babies receive a standard fortification that provides those additional calories, protein, calcium, and phosphorus. But sometimes even that isn't quite enough. It doesn't give them quite enough for growth. And what is fantastic is we can take a sample of mother's breast milk, so just 3 mLs, and put it in our milk analyzer pictured there, and really look at the composition. So it can tell us how many calories, it can tell us the protein and the fats. And so that we can see what would be best added to that milk to help that baby grow. Do they need additional fortifier to add those calories? Should we add liquid protein to support the protein intake? Or should we add MCT oil to support fat intake? And that allows us to continue to use mother's milk to our best ability instead of substituting in, concentrated formulas. So continue the provision of mother's milk while also supporting improved growth. So thanks for letting me share some of how we support breastfeeding in the NICU.
Thank you, Lois. And as we approach the top of the hour, we just want to finalize this presentation with one last slide, highlighting some areas of future work and opportunities. We want to expand human milk access and broaden donor milk availability in our NICUs, level 1 nurseries, and support regional donor milk partnerships. We want to continue investing in research and innovation to leverage UPMC's academic mission, to lead in lactation science, milk biology, and biobanking. And from this lecture, we've learned that there are many amazing things happening in this field. We want to empower families through equitable support, address disparities with multilingual, culturally grounded care, and hope to leverage technology for better outcomes with the point of care milk analytics that we just learned from, and improve clinical decision support tools as well. And finally, build workforce expertise. And this is why many of you are here today. Continue educational efforts among clinicians, nurses, and staff in evidence-based lactation care across our system. So with this, we finalize this talk. I hope you guys enjoyed it, and we're very grateful for the opportunity. Thank you.